The following program is brought to you by the McSilver Institute for Poverty Policy and Research. To learn more, visit www.mcsilver.org, like us on Facebook, and follow us on Twitter.
Hi, I'm Mary McKay, and I have the real privilege of being the director for the McSilver Institute for Poverty Policy and Research. And so thank you so much for coming to lunch, but most importantly, supporting the speakers who are going to share their work with us today. They recently traveled to Texas to present at the Society for Social Work Research. And so they were very well received at the conference, and I thought, my goodness, our community should know what they talked about and be informed as well. So thank you so much to our presenters. So let me just acknowledge a couple of very important people. So our Dean of the Silver School of Social Work, Linda Deca, is here, and she is a very busy dean and has been incredibly supportive of the McSilver Institute. So we really appreciate our dean coming, Robert Hawkins, the McSilver Associate Professor, and many of our kind of friends and colleagues in the audience. Also, we have somebody new to the McSilver community, so Dan Ferris directs our policy and external affairs kind of growing portfolio within McSilver. So Dan, very much welcome to the McSilver community. Gary is vouching, very personally for Dan. He works at NYU in government and community affairs, and did a really good job with NYU. And so we really appreciate you joining McSilver, Dan. Welcome. So those of you that know and those of you that don't, McSilver has a very important mission to address the root causes and consequences of poverty. And so we are really about at McSilver the rapid translation of new knowledge into new solutions for poverty-impacted populations, and to address really, and sometimes when I make a joke, I said our business is really to go out of business, to eliminate poverty, eliminate the kind of negative consequences. And so another important, I think, maybe not as clearly articulated part of our mission is not just that Robert cares about poverty, or our dean, or Mary McKay, or Gary, or our visiting scholar Robert Walker, but that in fact we are growing the next generation of poverty-focused scholars. And that's really who we have on our panel today. A set of professionals that are incredibly committed to poverty-impacted populations, incredibly focused on areas that can make folks' lives better, and to address some of the inequities that exist within our world. And so I'm really happy to have, I'm going to introduce all four of the presenters together, and then we're going to hold questions to the end so that maybe they can get through their presentations. But I'm going to start first with Micaela Mercado. She is going to talk about food insecurity and educational outcomes. Food insecurity that exists in New York, in the United States, one of the richest nations in the world. It's an incredibly growing problem in our city and in our world. And so Micaela's going to start first. Then Hadiza's going to take us through an HIV prevention program that was set in the Bronx, and some of her initial findings that will serve as a platform for some of her dissertation findings. She's working on her PhD in public health. Then Latoya Small is going to take us to South Africa. We're going to focus on HIV positive young people. Latoya is the project director of an NICHD funded R01 that's set in McSilver that focuses on HIV positive young people and their family, and how do we help them adhere to medication that hopefully will keep them alive and help them thrive. And then finally, our doctoral student, Mandy McGuire-Schwartz, is going to concentrate on needs of homeless families, the needs of their parents, the needs of the children, and potentially some implications for, I won't give it all away, Mandy, but trauma-informed care perspectives in setting family homeless shelters. So with that, I'm going to have Dr. Mercado speak first. Micaela has really done an amazing job supporting our new investigators within McSilver. She is the Chief Data Analytics Officer at McSilver, and I just appreciate her partnership and her mentorship to the next generation of scholars. So,
thank you, Mary. Welcome, everyone. It's really a pleasure to have you here today. So as Mary had indicated, I'm presenting on behalf of our research team that worked on this study with me, Nisha Bahari, Dr. Mary McKay, and Ms. Karadina Seal. And what we were really interested in this particular study was trying to understand how food insecurity may impact poverty-impacted families. And so what we know is that in 2011, when families around the country were asked through a national survey if they had experienced food insecurity, we found that about 10 million households in the United States, that's about 8% of the US population, had indicated that in the past 30 days they had experienced some sense of food insecurity. So this simply meant I wasn't able to buy food for my family, or I had to access it through food pantries. So just the gamut of trying to understand how food insecurity played in families' day-to-day lives. And then when we further looked into our literature review, we found that a lot of the families that are impacted by food insecurity are those who are headed by single female headed households. And this obviously led to children experiencing higher rates of food insecurity than adults. So what is the significance for this? What's sort of the issue or the problem? What we know is that through existing research that food insecurity is associated with a variety of negative or are negatively associated with several child outcomes or child-related outcomes, such as poor health. So children who experience food insecurity are at higher risk of obesity or also have higher rates of hospitalization. It also negatively is associated with their educational outcomes, such as lower math and reading scores, and also mental health or social and emotional difficulties are also experienced among children specifically who have families who've indicated being food insecure. So for our study, what we wanted to do was really try to better understand or gauge how food insecurity may play out in terms of how these children are doing in these families. So what we did was we proposed 3 research questions. We wanted to know who is accessing SNAP, which is the federal program that allocates food stamps to families. And we know that families who are eligible are primarily low income, right? There's a federal regulation that indicates if you're eligible or not, but we really wanted to really understand who these families were, sort of their characteristics. Then we wanted to understand that because you're a family that's experienced poverty, if this in some way is associated with children's educational outcomes. And then lastly, we wanted to understand if SNAP played any significant role in that association. So for this study, we conducted a secondary data analysis. We looked at a cross-sectional data set in 2011 from the National Survey of Child Health. And this is a national survey that asks questions to families about their children and their own experiences. The target age population is ages 0 to 17. And the study sample was approximately 95,000 individuals or families. So the variables of interest, we had a variable that asked families if they had difficulty affording basic necessities, and this served as a proxy for a poverty question. A question about SNAP participation, educational achievement. We looked at several variables for this, and the one that I'll specifically focus on is repeating the grade for this presentation. And then several demographic variables that could confound or be used as covariates in our model. So for example, we know that family structure plays a significant role in how families experience poverty and may or may not access SNAP. So for our first research question, we just wanted to know, so who's food insecure and who's accessing SNAP? So our final analytical data sample was approximately 14,000 individuals. About 70% of those families participated in SNAP. About half of the sample indicated they were single mothers, and about 60% were of minority status, and the average age of the children was 7.5. So just so we can sort of make sure that we're understanding this, this final sample are all families who are eligible for SNAP, but may not necessarily be accessing SNAP, and that's the number right here. So we have about 30% of families who did not access SNAP even though they were eligible. So then we wanted to know, well, are there any significant differences between these two groups, right? Those who are eligible for SNAP and not using SNAP, and those who access SNAP. And we found that there were significant differences in terms of who was heading the household. So those in SNAP were predominantly female, had younger children, had difficulty affording basic necessities, and had more number of children and less adults in the household. So for a second research question, now that we have these two groups, right, now we want to know, well, is being poor really, is it associated with the educational outcomes that we were interested in? And what we found was that there was a positive association. So this simply means that those families who indicated poverty, right, so that's our proxy, difficulty affording basic necessities, or had a 20% increased odds of indicating that their child repeated a grade. And then we wanted to control for those covariates, and we still found that the model was still statistically significant. That in fact, if you were having trouble affording basic necessities, regardless if you had children, the number of children or the gender of your child, the model still held. So then we wanted to know, in our last and final research question was, is SNAP associated in any way with these educational outcomes? And what we did was we entered an interaction term into our model, and we found that children of families not receiving SNAP had greater odds of repeating a grade compared to their peers. And so what this means is that if families who've indicated that they were poor and accessed SNAP, their children were less likely to repeat their grades, right? So SNAP is actually alleviating some of the household stress. So in conclusion, through the study, we found that families participating in SNAP are economically stressed. Poverty does have a negative impact on educational outcomes. It seems that SNAP may be moderating some of these effects, although we don't know the causality. And further research is needed to better understand sort of that relationship. Really, what is happening? How is SNAP helping moderate or having an effect on the outcome? So implications for policy and practice, we need additional research to better understand how SNAP or poverty affects families. That SNAP may be playing an important role, and with budget cuts, should we question that? Implications for clinicians and other additional preventative efforts is to really help families access SNAP as a resource to help alleviate some of the stress that they may be experiencing. And that maybe also better understanding how caregiver characteristics or family functioning may be playing a role in the experience of poverty and access to SNAP. So I will now like to introduce my colleague, Hadiza Osuji, who will be presenting the next study.
Thank you. So hello, my name is Hadiza Osuji. And Dan told me, we're going to have familiar faces, so it's going to be easy breezy. I beg to disagree. Not when you have our dear Dean, our beloved Mary McKay, Gary Parker's eyes going like...
A lot of pressure.
Yeah, so our presentation is titled, Do Community Members Train in Evidence-Based, in Youth-Focused Evidence-Based Program have an effect on youth outcomes? But before I go further with this, I would like to acknowledge Micaela Mercado and, of course, Dr. McKay, who co-presenters for this. So, and before I go ahead to answer this research question, I am going to give a brief description about our champion study, and based on the results of the analysis of the champion study, we'll attempt to answer this research question. So Champions is actually the umbrella name for 3 evidence-based programs that were adopted from CDC's programs that work. We have Be Proud, Be Responsible, Focus on Youth, and Becoming a Responsible Teen. Now, these programs target kids within the age range of 11 to 16. Of course, Be Proud, Be Responsible is for the younger kids. Focus on Youth is for the slightly older kids, 13 to 15. And Becoming a Responsible Teen is, it's for the much older kids, 15 and 16 years of age. Now, as you may be aware, the HIV and AIDS issue particularly among inner city, low-income, African-American and Latino youth is still significant. Although there are, the responses to HIV and AIDS has yielded successes, but the prevalence, the HIV incidence and prevalence rate so far is still troubling. We have more than 50% of all new infections occurring among adults and adolescents. And noting that, these young adults were probably infected during their adolescent stage due to the latency period of HIV infection, suggesting that they were also infected when, when they were adolescents. And also, of course, African American and Latino youth are still the ones that are disproportionately affected by this disease. More than 80% of all new cases are accounted for by this population. Now, apart from this HIV issue, we also have, there are a lot of evidence-based programs, that are out there. But the problem is transporting this evidence-based program to the target population, specifically, this type of target population. Researchers, have significant difficulties, doing this. And also they encounter obstacles, serious obstacles, trying to get community to endorse these programs. In addition, there are few naturally existing resources within the community to actually implement these programs. Most of the schools, the teachers are already overburdened with the curriculum, with the school curricula, that, taking up this task, it's an issue, to get them to do this. So with regards to the HIV/AIDS issue among this population, and also transporting evidence-based practices to the population, Champions, was developed to actually bridge this gap. And according to Dr. McKay, it serves to advance scientific knowledge with regards to community collaboration that can serve as the foundation for local adaptation of evidence-based programs. And that is what the core features of Champions are: partnership with the community. It is delivered by the community members, and the entire project is overseen by a community collaborative board. Now, the community collaborative board actually play a very important role in this. They are key stakeholders, within the community. They consist of parents, teachers, key representatives of community-based organizations that meet twice a month to, develop contextually and culturally relevant programs for, our target population. So they help to facilitate, to ensure that the program's objectives for the champion, is met, and facilitate the effectiveness of the program. And that is why the core assumptions of the champion study is that with community collaborations, we are able to address, we are able to address barriers to participation. In addition, the core values and the stressors and core values of these community members will be taken into consideration. This way, it facilitates, it makes the program relevant, and it facilitates, it creates buy-in, and it facilitates the effectiveness of the program. It also ensures sustainability of the program within the community, in the sense that champions train these community members to deliver this program, and in that way, they sort of equip the community members with the necessary knowledge and skills to act, as advocates for their health needs, and at the same time, they become established within the community as, natural existing resources. So this is the research design. The first step, we recruit these parents, and of course they complete pre-assessment, and afterwards, they go into training. They are trained depending on the program they belong, and then there is a post-assessment, and subsequently a 3-month follow-up. Now, with regards to the youth, they are also randomly recruited, and then they complete a pre-intervention assessment, and then they go through the program depending on which program they belong, and then there's a post-intervention assessment, and then 3 months follow-up. Now HIV, the training which these parents go through consists of 8 sessions, and they go through the curriculum, of course, of the program, and they they practice the sessions, and also we bolster their behavior management, their youth behavior management skill, and also how how they can form more positive relationship with this youth. So data was collected via self-report surveys, and of course, as I've mentioned earlier, at baseline, post-assessment, and 3 months follow-up. Data was analyzed using MANOVA and to examine the child mean score changes across the 3 time points. Now, our results show that with regards to the adult population, majority were African American females. 65% of them have children. And then with regards to the youth participants, for Be Proudly Responsible, majority are Hispanic females. Focus in Youth, majority are also Hispanic females. But for Becoming a Responsible Teen, that's BARD, the majority are African American females. Now, our findings show that across the 3 time points, stigma towards people with HIV reduced from post-test to follow-up. And also, HIV knowledge, their HIV knowledge increased from post-test to follow-up across, to follow up with regards to the 3 programs. And also when it comes to comfort discussing sexual topics, there were also significant changes from post-test to follow-up. So our results, therefore, shows that implementation of evidence-based programs by trained HIV mentors, yielded effective results. And the limitations of the studies, of course, is the self-reporting and also missing data, as well as maturation effect due to the age difference, amongst the kids from Be Proud, Be Responsible to BARD. And the implications for the study, of course, is that further research needs to be conducted to examine the roles of community members as facilitators in translating research to practice, and also to look into the impact of trained community members, in yielding effective results. And of course, I would like to acknowledge and give thanks to our funders, the National Institute of Mental Health, and of course our Chandler's community coordinators who did a tremendous job. And we have them in the audience, Janet Watson, who is expecting her first baby. I'm going to give it all out. And Anita Rivera. And of course, the New York Community Collaborative Board and Mount Sinai School of Medicine that housed the program initially. Thank you. And of course, I would like to call on Latoya Small to take up the next presentation.
Okay, so we're going to South Africa. So the title of my talk was New Challenges for Young Generation, Understanding Medication or Medical Adherence and Mental Health Among South African Perinatally Affected Youth in Early Adolescence. And I'd like to acknowledge Dr. Mullins at Columbia and Mary McKay here for their collaboration and support with this presentation. So the goal of this was really to look at secondary analysis from baseline findings from a pilot that was conducted in South Africa with perinatally infected youth who were aging into adolescence. And we really wanted to look at their mental health, and their medication adherence. And part of this is to really look at how we can establish a family-focused as well as culturally aware intervention that can inform the South African care system as well as further future research. So the background is that before 2004, antiviral medication, ARTs, were not available to children in South Africa. Most of them died before their 5th birthday. Those that lived to their 5th birthday did not live to their 10th birthday, and even less lived into adolescence and beyond. However, with the introduction of PEPFAR, more ARTs became available, and now there are over 100,000 children receiving ARTs in South Africa. Fortunately, that's still less than half, but we do have these new groups of adolescents aging, perinatally infected youth aging into adolescence and beyond that we get to learn more about within the cultural context. What we do know so far stems from children who are perinatally infected in the U.S. And a lot of them had access to ARTs far earlier than those in South Africa and a lot of other countries. So we do know that they have difficulties with medical adherence and mental health. And it gets really challenging as they approach adolescence. Because if we all think back to the joys of our youth, there are all these complex real-world issues. So there's peer pressure, there's school, there's changes in your body, there are issues around drug use, there's issues around sex, and you take all of those and you compound that with poverty and HIV in a low-income area, in extreme poverty in South Africa, and that's what the children in our study are facing. So already here in the U.S., we know that HIV can really impact the central nervous system, and it can really impact neurocognitive functioning as well as mood. So it's not surprising that a lot of seropositive youth have trouble with adhering to their complex regimens of HIV medication. And a lot of that means they're pretty inconsistent in taking their meds on a regular basis. So what does our study look like? For the participants that we spoke to, we really looked at the baseline findings. So we had 2 hospitals in KwaZulu-Natal, South Africa, which is one of the most highly dense areas that have adults and children with HIV. And we looked at the baseline. And then we provided the BUCA intervention. We did a 3-month post-test, and then we interviewed them again 12 months after baseline. And we compared this to the standard of care. So again, we're looking at baseline, but this is the intervention. So what do they talk about? Well, it's a 10-week intervention called BUCA, right? And we follow along this little boy here. His name is Temba. Temba is orphaned by a mother who died of AIDS. And Temba now lives with his family, his aunt and her family. And not everyone in Temba's family is happy to see him. So the adults and the youth in our study follow Temba weekly and deal with different issues around stigma, disclosure, sex, drug use, in group settings that are relevant to South Africa, children in poverty-impacted townships in South Africa. So who are the participants? Well, the adults are primarily female. They're around 43 years old. The women are slightly older. Most of them did not finish high school. Even more of them did not complete the 8th grade or go beyond the 8th grade. Most of them are single, but we do have some that are married, although we don't know the specifics about their marital status and relationship. In terms of the children, they're about almost half between males and females. The average age is 11 and a half, with the males being slightly older, and most of the children here are in grades 4 through 6. So we use standardized measures of the Strength and Difficulties questionnaire, as well as a questionnaire that had been empirically tested through study with other perinatally infected youth. It's a tongue twister, that. So what did they tell us? Well, the good news is that a lot of parents reported on the SDQ that their children didn't really have serious behavioral difficulties, and they didn't have serious conduct difficulties. So 90% or 80 to 90% of people, or caregivers, reported no problems in conduct, hyperactivity, peer problems, overall difficulties, but they did have concerns with their children's pro-social skills were involved. And they also had concerns in terms of their child's emotional impairment and their emotional functioning. So about half were reporting that they had some concern about some emotional symptoms that were beyond normal. In terms of the adherence, a lot of the caregivers were reporting that parents who monitor their child's medication had youth who adhere to medication, right? So if your parents watching what you're doing, then you're going to take your medication. Also, if youth who have better pro-social skills have parents who help them take their medication more, which is a concern when so many parents report trouble with their child's pro-social skills. Because that means trouble getting help from your parent taking your medication. Lastly, well, not lastly, but we also thought about that parents who have knowledge about adherence or knowledge about the regimen that the children are on report lower total difficulties in their children. And then we did a holistic regression that kind of informed the study, and children were reporting that the older they get, the less reliant they feel they are on their caregivers, which is also a good sign. So we do know that this study has limitations, right? We still rely on self-reports. We also know that it's a small study. It's a small sample size, so it's not really representative. And there are other, and of course we have our covariates and left out variables. So the implications, though, are that this population, even with its limited resources, is pretty resilient. But there's a lot of, that parents are reporting that their children are doing well in a lot of areas, right? It also talks about how parent adherence knowledge really does impact your child's medication. And then this also helps us understand that when we have, that we can really build an evidence-informed psychosocial intervention within the cultural context of South Africa to really help with functioning and emotional impairment with this group. That's what is gluten. So before I close, I'd like to acknowledge the National Institute of Nursing Research that funded our pilot study, as well as the Human Science Research Council based in South Africa, that are our collaborators there, as well as the National Institute of Child Health and Human Development that has really helped our current larger group of study that helps us follow up on a lot of what we learned in our pilot. Thank you. Next we have Mandy McGuire-Schwartz.
Good afternoon. My name is Mandy McGuire-Schwartz, and I'm going to be talking with you today about a study that I worked on along with Latoya Small, Gary Parker, Mary McKay, and Patricia Kim. And this study focused on looking at relationships between caregiver exposure to violence and caregiver depression and youth behavioral health among homeless families. So we were particularly interested in this topic because we know that there are a lot of homeless families out there, and we also know that there are high rates of trauma exposure among them. The data that we used for this study came out of a previous study that was done several years ago, which looked at a HIV and drug abuse prevention program with homeless families. This was a family-based model that worked with 248 youth who were primarily pre-adolescent and early adolescent youth. And their caregivers who were, some of them were parents, some of them were other relatives. So half of those youth participated in the Hope Family Program, and half of them participated in a basic health education program. This study was supported by NIDA and also benefited from the work of the Community Collaborative Board. So this study involved the secondary analysis of the baseline data from the Hope Family Program study. We looked at a slightly smaller number of youth because we were looking at just the first youth in each family to register for this program. There were a number of families that had more than one child in the program. And we were interested in looking at the relationships between stressful life events, caregiver behavioral health and substance use, and youth behavioral health. So we looked at a number of standardized measures that were collected upon baseline. These included 6 questions from the City Stress Inventory, which basically asks about exposure to violence within the past 6 months. It's things like being mugged, knowing someone was stabbed or shot, being sexually assaulted, as well as the brief symptom inventory, which looks at adults' mental health. 16 questions from the Children's Depression Inventory, which is a measure of depression symptoms among youth. And the Strengths and Difficulties Questionnaire, as Latoya had mentioned as well, which is a questionnaire that parents complete about their child's behaviors and symptoms. And we were looking particularly at behaviors, including hyperactivity and conduct problems. So we did some univariate and bivariate analyses through SPSS. And then we also analyzed multivariate relationships using SEM through AMOS. In terms of demographics, the sample was quite diverse in terms of specific ethnicity. There was some missing data. Not everyone provided information about how they identified ethnically and racially. But overall, the majority of participants were either Black or Hispanic. A number of them identified as both Black and Hispanic, and a smaller number identified as neither. And in terms of gender, there were slightly more male participants, and the caregivers were primarily female. So going back to those measures that we looked at, when we took the means of each of them, we found that there were pretty high rates of fairly recent exposure to significant experiences of violence among both the caregivers and youth. It was 2.7 for caregivers and 2.5 for youth. Each had a range of 0 to 6. And in terms of caregiver depression, youth behavioral problems, and youth depression symptoms, it was common for some of those symptoms to be reported, but the overall rates were fairly high on youth. So when we did some bivariate analyses, we found that there were statistically significant bivariate relationships between caregiver violence exposure and caregiver depression, as well as between caregiver depression and youth depression symptoms, as well as youth behavioral problems, and also between youth depression symptoms and youth behavioral problems. This is the multivariate model that we looked at. So we were looking at the relationship between caregiver exposure to violence and youth behavioral problems and youth depression as mediated by caregiver depression. And we found that each of the pathways in the model was statistically significant, and the model did have good fit. So we conclude that caregiver violence exposure does have a statistically significant relationship with both youth depressive symptoms and youth behavioral problems as mediated by caregiver depression. Caregiver depression. So some of the implications of these findings are clearly that youth behavioral health is associated with caregiver mental health, which in turn is associated with caregiver trauma exposure. And this highlights the importance of taking into account adult mental health while treating youth, whether treating externalizing or internalizing symptoms among youth, and also making sure that caregivers have access to adequate treatments and supports themselves. And it's also important that this treatment be trauma-informed, given the links between trauma and mental health. But of course, there are some limitations. For one thing, the sample may not be representative of all homeless families. And since we use a cross-sectional design, we can't really determine causation. The measures were based on self-reporting, so there may be bias related to that. And in some cases, a subset of questions from the measure or a subscale were used. So the validity and reliability may be different from those of the overall measure. And also because there was some missing data and some use of post hoc analysis, further research should be conducted to confirm these results.